Council meeting. Great. So the first order of business today is I'm going to report out a few updates. I first want to let everyone know that we have hired a new director for our analytics team here at the Green Mountain Care Board. Her name is Wendy Geller, and she'll be starting in June 16th. She starts. Is there a little background?
I'm not sure.
Okay, can you all hear me okay? And there's no background for you? Okay, we'll just keep going. So she starts June 16th. Wendy worked for the state of Vermont for many years at the Agency of Education. And then she moved into a contracting role at a company called AEM. And don't ask me what it stands for, but it's a federal company that works with the federal education. But we're excited. She's coming back to serve at the state of Vermont, and we are really excited to have her. But I want to take a moment here to thank Lindsay Kill, who has been interim director of our data team over the last, not that Lindsay's counting, while. But Lindsay has gone above and beyond, not only leading the entire team, but taking on work to keep things going that a lot of people don't even see. So I just want to thank her, and we are excited to see what Lindsay and Wendy can do together. I mean, two talented people, Wendy as the director and Lindsay as the deputy. So we're really excited about that. And thank you again, Lindsay.
Oh, thanks, Susan.
Really appreciate it.
Yeah.
Another announcement, we have an opening posted, and it's been open for a while, but we are now recruiting for it because of timing with our regulatory schedule. And that is the Director of Health Systems Finance. So it's essentially the person who runs the hospital budgets and then also helps with our other regulatory efforts and informs on the finance side, ACO regulation, CON, certificate of need, et cetera. So that is posted on our website. And if you know of anyone interested in working at a great organization at the state of Vermont and has finance and budgeting skills, that would be great, among other things. And then the last thing, and Lindsay's going to help me with this one a little bit, is, and I see Will on the screen too, so he might want to chime in. We just finished, well, the legislative session hasn't ended yet. But it's mostly done. There's some education stuff they're doing, but all of our things have been passed out of the legislature. The governor hasn't signed any of these yet, but I expect them to be signed, but I can't say for sure until they're actually signed. But the one bill I wanted to bring up because it is relevant to our work is S-126, and specifically section 10. And that is looking at pursuing integration of clinical and claims data. I know Lindsay and Will Dempsey and folks at the Healthcare Advocate really worked hard together this session to come up with language that gets us to a good place on that. And I don't know, Will or Lindsay, if you want to pull out anything relevant here that folks from the Data Governance Council should know. And we could come back to it as well as we're moving through it.
Yeah, maybe once we get to that section, but I do like that you called out that it was a joint effort, which is really exciting. And I'm very thankful to have gotten to work with Eric and Will on that. So thank you.
I think we landed in a good place. And then the last thing I'll say is the Green Mountain Care Board, and I'm looking at Tom as one of the board members, is getting ready to start their busy regulatory summer. We've received the qualified health plan exchange insurance requests. They are quite high. So we have a lot of work to do there. And then the hospital budgets start shortly after that. We'll receive those budgets July 1st, and then hearings throughout the summer. And then related, there's been a lot of work both in the legislature and with AHS and with the Green Mountain Care Board and with the healthcare entities to address a lot of the issues around healthcare affordability and solvency for our entities, and that work continues. So those are my updates. Does anyone have any questions? Okay. So the next item on the agenda is the approval of the April meeting minutes. Do I have a motion?
I'll
So
move.
moved.
I'll second.
Okay. Any discussion?
Just that my name was misspelled in it.
Okay, that's important. We will address
Sorry.
that. Thank you, Larry.
Not a big deal, just in case it matters at all.
Yeah, we
Yeah.
like to get things right. So thank you.
It was in the
Okay,
body,
all
not in the top part.
Okay, great. All those in favor, say aye. Aye.
Aye.
Aye.
Okay, great. And then the next item on the agenda is the DUA application for the Virginia Commonwealth University, and I will turn this over to Lindsay. Yeah, great.
Thank you, Susan. We have the applicants from Virginia Commonwealth University here today to talk about their application. So I'm just going to point people to where it is on the website here in case you want to go look at it again, but I'm also going to turn it over to Daniel and his colleagues if you all want to share about that. And if there's anything you need me to like point to or navigate to directly, just let me know. Or I can just stop sharing while you talk if that's like distracting, whatever works for you.
No, it's fine. You can share. I'm not sure if I'm going to need you to point to anything because this is a pretty like
Okay.
cursory overview of the research study that I'm proposing. But essentially, I'll give you a little bit of background on me. So I'm an assistant professor at Virginia Commonwealth University in the School of Social Work. Before this, I was a PhD student at New York University, and before that, I was a clinical social worker at the Howard Center in Washington County Mental Health for about a decade. And so I've been involved in mental health care and substance use care in Vermont for a long time. And part of my work there overlapped with OneCare's Pay for Coordination initiative to that kind of revamped over time to enhance care coordination, both among primary care physicians, but also less so in the community mental health system. And one of the things that I've noticed from like following the behavioral healthcare system in Vermont, I did my dissertation on a payment reform mechanism impacting the designated agencies, is that OneCare has not been very thoroughly evaluated in a public way in relation to behavioral healthcare, and pay for coordination financing mechanisms haven't been in the literature very frequently for behavioral healthcare either. And so I thought this would be a great opportunity as I'm getting started in my assistant professor position to use some data from a context that I know fairly well in order to add to that literature. So what I was hoping to do is looking specifically at people who receive medications for opioid use disorder from their primary care physicians, see what coordination of services looked like for them, whether if they have co-occurring disorders, whether they had increased access to mental health services, whether they were retained in mental health care longer, and if emergency department visits were decreased because of that. Because for people with co-occurring opioid use disorder and mental health problems, there tends to be much higher rates of emergency department utilization, there tends to be lower retention and treatment, and higher suicide rates. So I thought it could be an impactful study, especially if OneCare's initiative was effective in enhancing care coordination for that population, and add to the literature. I applied for some funding. I have some internal funding from Virginia Commonwealth University for the study to both enhance my methods training and to pay for the data. And I applied to Cherish, which is a multi-university kind of collaboration that funds this sort of research, and was not funded through them, but I have access from that application to methods consultation and additional mentorship from them in conducting the study.
Great.
Would you like to share? So I'm just trying to navigate without too much scrolling to like bother people's eyes. Would you like to share just the overall? Sorry, would you like to share anything else about the study before I pull up some of the application on the screen, or do people just want to open discussion? Or
Yeah, unless,
That's
okay,
yeah.
Yeah.
Daniel, do you have anything else or, and that's
Um,
fine? Dr. Costa?
I'm not exactly sure what you all need, and so I'll stop
Yeah.
there. And if you have questions,
Yeah,
then
okay.
I'm happy to answer
I
them.
think that would be great. So Lindsay's gonna pull up some of the application
Yes.
details.
So I'll just start by saying that we did our internal review and we are recommending to accept this DUA or approve this DUA request. There's no, it's just the Medicaid and commercial data. We think it definitely has great, could like impact Vermonters. It's like a great resource to have. It's a really fascinating research topic, and we felt that the what's it called, the security in place seemed adequate to us, so that passed our internal check. So we're recommending that this be approved. The only question that I had, and more just for like the record, so it's in the notes, is what you call pay for coordination. Is that the fixed prospective payment to the practices, the ACO fixed prospective payment?
So it would be, this is something, I'm not sure if it is the ACO fixed prospective payment. Let me see if I can quickly find the one paper that's been written on this.
Sure.
To give you, so the language they use. So Centers for Medicare and Medicaid Services conducted a case study of OneCare, of their community care coordination program. And the reason I don't think it's a fixed prospective payment is because there was a prospective payment element to it, but it was also a reimbursement for care coordination services received after the fact. So it was like this, it was like kind of a hybrid on top of fee-for-service payments that for mental health agencies they were already receiving. And I found it.
Interesting.
Good question, Lindsay.
Yeah, interesting.
Yeah.
Okay, I don't think I knew that there was like another
Layer.
of payment. That's very cool.
So I think this is one of the issues with OneCare is that I think there's a lot of stuff that hasn't been like really clearly documented around how they operate and across many different types of agencies. And so one of the things I hope to do is, as OneCare is wrapping up this year, to be able to add some of that to literature. And then hopefully, like if the AHEAD model moves forward, which some of you will probably know much better than me how that's going, to position myself to study that in a similar way across multiple states.
Awesome. Should we open it up to questions from the council?
Oh, yes.
Yeah, Kate already has
all right,
one.
there you go. Hi, Kate.
I do have a couple of questions, and one is related to the study itself. I think I'm asking my question a little bit differently than what you did, Lindsay, but I did also notice that term pay for coordination. And what I wondered about it is, because it's not a term I'm super familiar with, but would you expect to see bundled services in that payment, or is it like a specific thing that is they're paying for the coordination? Like, could you just explain that a little bit, like what you expect to see in the data when you are studying that? Yeah,
so pay for coordination is an alternative financing mechanism to bundled payments. And it is generally classified under a blended payment model because it is an adjunctive incentive payment that's usually combined with either an already established capitated rate, which is what I think happened with the designated agencies after 2019. It was blended with that, or blended with a fee-for-service rate. And it tends to be like a monthly payment that goes out per person as a reimbursement, not prospective, so it doesn't look quite like capitated payments, and it's not necessarily fixed in a capitated way based on number of service users. It's really like an established fee just to kind of bump up service utilization of case coordination. And so what I'm expecting to see in the data, and this is one of the limitations of this study, is that I haven't used claims data before. All of my research has been in electronic health record data. And so, but I'm pretty sure that there should be specific CPT codes for care coordination that are in the claims data that that would be the same services that would be incentivized by the pay for coordination method measure. So, so by just tracking those CPT codes, I would be looking at whether that service was provided. And I also, the way the Vermont behavioral health system tends to work is even if you incentivize like one specific thing for one smaller group, the agencies, and I think this is true for primary care practices too, the agencies can't necessarily just tailor their services just for that one group. They tend to have to do like a blanket change. And so it incentivizes care across the board for everyone. So even if someone wasn't, even if like a primary care practice wasn't eligible for reimbursement for coordination services for an individual, I think it would still show up as increased care coordination if they're seeking to get that reimbursement. If you want, I am very unfamiliar with Teams, but I can share the CMS document if there's a chat function here that talks specifically about the community care coordination program. Would that be
Or you can
helpful?
email it to us and we can share it out with the group too.
Yeah.
But there should
Yeah.
be a chat function unless we shut it off.
Chat's turned off.
Okay, I
Okay.
will.
Oh.
I will email it to Ravi, who's
Great.
the person whose
Yeah.
email I know I have.
Great, thank you.
I have another question, but it's security related. So maybe I'll just stop there in case Laurie, I see you have your hand up if you have questions related to the study itself.
No, go ahead. I have a security question too.
I just noticed the reference to your laptop, and I wanted to just ask about the not really sure what my question is, but it seemed like an alert. Usually there's a, it's in a secure space and it's accessed by potentially like a laptop for use, but not stored on the laptop. And so I don't know if this is really, I'll start with you, Daniel, but it might be a question for Josiah or others here in case there's some consideration about that, or just to alleviate any, thing that may be a concern to me.
Yeah, so what I'm requesting, I believe, is a limited use data set. And for Virginia Commonwealth University, that designation allows it to be stored on an encrypted laptop or desktop computer owned by the university and monitored by the university, accessed only when connected to university Wi-Fi. And so if there was anything beyond a limited use data set, it would have to be through VCU stored on one of two designated servers for electronic health record or claims data that are also, they're not ideal for a researcher like me to use because they're also the same servers that are used for people doing very high level complicated analysis and machine learning. And so like space and time and access to them is limited. And as junior faculty, I have more access than a postdoc, but I still don't have the access that a postdoc does on a much more prolific researcher. And so it would be frustrating and difficult for me to do the study in a way that's like timely and works with my workflow. But it also isn't something that I would say I wouldn't walk away from it if that was a requirement from all of you to put it on a secure server and access through one of those two avenues.
I see. Oh, that's a very helpful explanation, actually. And the only other thing that I'll say is it's a limited use data set, but it's still very heavy. So there may be I don't know. You may find that you're unable to access it, actually, even that you wouldn't be able to store it we wouldn't have the capacity. But that I don't know, but that's more of a logistical issue.
Yeah, so this is Josiah, and I'm the IT guy. So yeah, in general, we do not want this data set on laptops. So I appreciate that it's encrypted and monitored, but I would prefer that be stored in your university managed data center and space there. The other kind of related thing, and this is what flagged it for me as a laptop too, is the data destruction just becomes more complicated when it's on a personal device. Too easy for copies to exist. So getting the certificate of destruction just harder when we're working in a laptop environment. So yeah, I would say from my perspective, use the university's data storage facility and do your compute there. Thanks.
I'm happy to make that change for sure.
Valerie, did you? Yeah. Oh, sorry, Tom. Go ahead. I don't know who's.
Lowry, did you have questions along the same line or something separate?
It was exactly that issue.
Okay.
Thank you.
Okay.
Great. Okay.
Could I ask a similar question? I'm not familiar with the our workflow within the state or VCUs, and it's been a long time since I did my large data set research. So forgive me if they're just inappropriate questions. They're too simple, but with the type of questions that you want to ask, Daniel, would it be possible for questions to be crafted that would cull from the large data set into a cloud stored small data set for the question? So it would not have to live on your laptop or it would stay in our realm. It would be made available to you. I'm struggling thinking about it sounding like data being moved like in a briefcase, but we don't have to move it in a briefcase. Right? Is there a way, Josiah, and again, I'm far out of my field, but is there a way that an analytic data set for the question at hand could be created, stored in the cloud, and available for Daniel? There's going to be another analytic data set for the next question.
I believe that one of the questions gets at that, and we offer and maybe this is not exactly what you're asking, but we offer that the research can be done, within our enclave, so the data doesn't transfer and they just get the aggregates that they need to do the research. But I think Daniel put in that would not be ideal and laid out some reasons why that would be the case. So I think yes, even if we transfer it to the university through SFTP, which I think is laid out in the document, once Daniel creates aggregates in the university's space, then he'll be able to work from that for whatever the final output paper ends up being.
Okay. Um, Ravi, I see you nodding. I don't know if it's because of anything I've said or Josiah's said, but you've helped me understand some data flow things. So what are you thinking?
Yeah, thank you, Tom. So what we were thinking is, like if we have provision access for Daniel in our enclave, like contractually we incur additional costs for that seat, and like there is a whole set of things that we need to take care of at our end, right? Whereas, if just like Josiah was saying, if Daniel can work with their internal teams and then have a storage space made available for regular process for OnPoint to send the data directly to them. And then I think Josiah explained it, on how he can extract that data, and then Daniel can use it for his research. Make sense?
I think so. And I think in my experience, Daniel, it's some more work up front to more tightly define the variables that you want and how you might how you would describe them, modify them, create new variables out of it. I'm even forgetting some of the jargon, so I feel like I'm fumbling for the right description. But it's more work up front, but then the data set becomes much more manageable and of course remains completely de-identified, and it's just easier to use. So that was my thought reading it when I saw the laptop. I was, why would we need something stored on a laptop? It can be outside of there. But again, I'm a little bit out of my field. But other than that, like the word laptop showing up, I thought this was really well prepared, and your security concerns, the management of this, I thought was really well laid out. It was a well done DUA.
Thank you. Yeah, as part of the grant applications, I have a full analytical plan that gets at the specific variables and what variables would be constructed to. And one of the things that I would want to talk to OnPoint about is I do not need variables I don't need. Like that does
Right.
nothing to help me, but I also don't want to incur additional costs from OnPoint, asking them to do anything to the data.
I see.
Because although I have funding, it is like funding in the academic environment right now is very precarious.
Yeah.
And I don't want to spend any more than I have to.
Any other questions from the council members?
Kate, did you have?
Go ahead, Tom. What?
Kate, did you have more questions regarding the data or the analysis?
I do not.
So Daniel, I found this intriguing and exciting. I had not heard about pay for coordination either. I've heard of pay for reporting, pay for outcomes, and so this isn't a question that would. I fully support the DUA, but I wanted to understand that a little bit more. Are there, in your understanding of pay for coordination, how's coordination measured? Are you sure yet, or is that part of what you'll be exploring and reporting on?
So in this study, coordination would be measured through the CPT codes that identify service coordination or care coordination. And that is one of the limitations of like a large data quantitative study. Is it like that's not a great definition, because care coordination can look like many, many, many different things. Yeah. And one of my hopes for this would be a pilot study for me, and beyond this, looking to see if the AHEAD model incorporates this sort of tool. It would be a mixed method study that really gets at how are primary care offices doing service coordination, particularly when there's in different states, wide variability of their ability to pay for social workers or bachelor's level case managers. How do they account for mental health care because there's disparity in payment for mental health versus substance use care in primary care offices. And so those sorts of qualitative questions like really interest me, and they're next, I think. I'm hoping they're next, because there's also, I think there's like a sad chance with this study that there isn't much change. Even though there's incentive payments. A lot of what I found looking at other incentives in Vermont is that and this is true, like internationally, actually, the research supports this, paying providers without any other like quality measures, paying providers to change their behavior doesn't work very
Right.
well.
Right. And also, allowing them to define the measure themselves.
Yeah.
Which
Yeah.
we've also seen with reform efforts. So coordination is, did I attempt a phone call?
Yes.
Right. So that's what intrigues me about this. And just a little bit of, you didn't ask for my advice, but a little bit of unsolicited advice. I'd caution against tying this to any one type of reform effort, whether it's a head or another acronym, because I think it's valuable beyond that. And the acronyms change at least every 10 years, sometimes quicker. And so,
totally.
right. And so just, I think where there have been studies that have shown well-defined, coordinated efforts improve care, those can be built on to show that this is something that health systems should be undertaking. Their leadership should be concerned, regardless of the acronym.
Oh, totally.
This improves outcomes, which is a cost management strategy. Like, poor outcomes cost money. So for the organization and for the country and for the state. So I think you're onto a really good thing. And rather than trying to peg it to ACOs or a head, it's health system performance.
Yeah, that makes a lot of sense. Thank you.
Best of luck. I hope to keep hearing about it.
Well, that's one of the things I wanted to ask you about, and this might not be the right conversation for this, but one of the things I care about, having done so much work in Vermont, is making sure that I can present findings in Vermont and make sure that you all know what the outcomes are, but trying to figure out a way to make sure that providers know what the outcomes are. I think at least when I was a provider in Vermont, like, we were very uninformed of what was going on in policy. And when we were informed, we didn't understand what was going on in policy and what. And so I would love to find a way to partner with whichever one of you might be involved in that, to make sure my info gets disseminated beyond just like the academic journal articles, but to actually bring it back to the state.
Yeah, no, we'll make sure we've done this before where, and I'm looking at Kate because she was the director there, maybe on, with
I
like
remember.
the ED, SUD study. And, so definitely, any of us will make sure, I will make sure that happens. I'm the executive director of the board itself, but I think, we're all interested in hearing and can look to either have a presentation here or at the full board itself and make sure we disseminate the results.
Yeah, I'm pretty sure I've heard of two where it was data that, it was a DWAY that got approved, researchers were able to use our data, and then they came back to present their findings in a public forum, and it was really helpful. And so, yeah, I think that would be great.
I'll just chime in to say I would encourage that. One of the criteria for review of studies to release our data for is whether it benefits Vermonters. Clearly, this, is a study on Vermonters, and it would be of keen interest to a lot of interested parties, I think. And secondarily to that, from time to time, it benefits us, frankly, to showcase the ways in which our VCures, our APCD data are used. And this is a great example of that. And so I would encourage you would stay in touch, of course, with the team anyway, because you'd be accessing our data. But as you prepare your report, staying in touch to consider how and when you'd be able to present this, I think you would have a very interested audience.
Great, thank you.
Yeah, I think from the data governance side, I'm interested. We might learn some things with how you do this, how you pull things together and how you do things. I also think it will be important for our health policy team to understand what you're doing and the results. We have a renewed push toward incorporating quality measures in our budget assessment of the entities we regulate. And care coordination is an important quality metric. So how it's defined, how it's monitored, what people do as a result, all of those things matter. So I think there are multiple places that I internally that I think it's important we stay informed and learn from what you do. What I also heard you ask was guidance or help with disseminating it to providers. And other than having you present to us at one of our public board meetings, I'm not sure what to do. So I think that that's a question that we should think on further. We have guest speakers that talk about their research, so that's obviously something that I would think we could do. But my sense was that you were looking for something a little more than that. So I think we should. I don't have a good answer right now, but it'd be helpful. I think it's good. It'd be good for us all to think about it together.
And Lowry works for Bi-State Primary Care, which is all the federally qualified health centers. I'm sure he can help get the word out.
Newsletters, those, yeah, it's a good idea.
Yeah, we have an annual spring conference which just happened, but
Right.
a future one could be interesting.
That's great. All right. That was a great discussion, and thank you, Daniel. Thanks for answering all of our questions.
Yeah, thank you.
Any other questions from the council? Okay, we have a potential vote. I think we should vote on this. So the motion, I can do the motion. I motion that we approve the DUA application for Virginia Commonwealth University.
I'd like to amend the motion.
Oh, yes,
have-
please.
Oh, I just
Yeah.
have a quick question. So Daniel, would you be able to submit a revised application with that laptop, like removed, and after you talk to university folks, of course, but once you submit that, then I will update it, right?
Yeah,
Yeah.
is that and we can amend the motion to Josiah if that's what you were going to say?
Yep.
Yeah, so-
So accept as discussed to
Yes.
use the university's network, not the laptop. That'd be the amendment.
Excellent. Thank you, Ravi. Thank you, Josiah. And do I have a second?
I'll second.
Second,
Okay, thanks. Any further discussion? All those in favor say aye.
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 That has passed. Thank you all. Thank you,
Thank you.
Daniel. You're welcome to stay, or you can move on and get.
I do
into
want
some
to.
of your research.
I wanted to. just wanted to get past the vote first, but before you leave, Daniel, I just wanted to say hello.
Hi.
You've been interested in VCure's data for many years, and you and
Yeah.
it's me. You and I have had many emails back and forth from some long time ago now. So it's nice to see you, and congratulations. I'm glad you made it to this point, and you've been approved for the DUA. Good luck.
Thank you so much. You were very helpful in keeping me from making my dissertation way too complicated. And so thank you. Okay. Thank you so much, everyone. I will send the updated application to Ravi.
Excellent. And then we'll be in touch about some follow-up after it's done.
Sounds good. Take care. Bye.
Presentations. Thank you. Take care. Okay, so the next item is the data reporting manual changes, and Lindsay is going to do that as well.
I'm just going to go over everything at a high level, and with a little bit of background. So just to give a little bit of background, I'll even go to the about screen so you can't get lost in the details. But so as part of our this current VCures contract that we have with OnPoint, we call it our VCures 4.0 contract. It started in August of 2024. As part of that work, we have in that contract to further develop the infrastructure in the all payer claims database, VCures, to include non-claims payment. So the APCD Council, which is a larger organization, a national organization, they developed the common data layout, the APCD common data layout. And as part of that effort, they developed an infrastructure through that group. They developed an infrastructure for non-claims payments. So basically, how can we be collecting in a way that we could put in the APCD, collecting this information on payments and services rendered that's not necessarily tied to your usual claim, like your CMS 1500, your UB04. We have some of this information to date for some payers, but it's not standardized. We don't have it for all payers, and we don't capture all payments. So in the past, we've sort of solved for this gap with supplemental reporting, either from the ASSR, supplemental reports and expenditures, or we request, sort of as a one-off from different payers, can you fill out this Excel spreadsheet and tell us about your non-claims payments? So this is really, it's part of a national push to incorporate non-claims payments into APCDs, but also it's part of our contract with OnPoint that we would start this work. The work kicked off in February of 2025. OnPoint really led the effort on behalf of the GMCB with commercial submitters and Medicaid to start collecting this information. And so what that looked like was interviews with the different stakeholders to learn from them what kinds of non-claims payment information do you collect? How do you collect it? How is it stored? Is it something that could be transferred or manipulated to be added to this extract, these submissions that we get with our current claims extracts, so on and so forth. So it was really like a collaborative approach to designing this data reporting manual change, which I'm excited about. And so the result of that is what OnPoint has put together today is the non-claims payment changes. And so what submitters are going to see is in the table of contents, it looks like 6, but it's really just the 3 files. So there's an annual payment file, a pharmacy rebate file, and a capitation file. And then there's some submission examples. Everything that's in yellow is where there's changes. So I'm going to skip over where there's not changes. The proposed changes here on the general file specifications, this is just like a high level overview for the submitters of what would be included. So the file type, the covered parties, and the required frequency. There was some discussion around getting the data more frequently. So we have some submitters who submit monthly, some who submit quarterly, and some annually. And through feedback from submitters, we've decided that it really is best to keep it annual for now. This will already enormously improve our reporting and our understanding of utilization and expenditures throughout Vermont, even to have this annually. So I think this is a great starting point. And it will reduce the burden on our submitters. So annual submissions for those. The change log here, which is something that you can sort on, and we just have it sorted here for adding these layouts. And then there are these new types of files fields to mark. Right now we get eligibility, medical claims, pharmacy, and dental. And then again, we're adding 3 file types: annual payment, pharmacy rebates, and capitation. And so the actual file layout is on these 3 tabs: annual payment, pharmacy rebate, and capitation files. So submitters can see that there. And then OnPoint's included some submission examples, they do outline like what some of these fields will look like. And so, and just to give you a sense and give submitters a sense of like how this should look so that the analysts can actually use the information. So these are, so it's a proposed change to add non-claim payment structure to the APCD, but it's really 3 affected file types for 3 different types of submissions. It's Wesley. Blue Cross, sorry.
Oh, sorry.
Yeah.
Okay. So one thing, and I think I just want to say, just to clarify, and then Leslie will let you ask your question.
Mhm.
It sounds like the payers have been socialized with this, and you all in OnPoint have been working with different payers on these changes, getting their feedback over the last several months. Is that correct?
Yeah, some payers, I don't know. Some payers, not every submitter.
Blue Cross Blue Shield of Vermont is one of them.
Yes.
Working with.
Yes.
Okay. And great. And Wesley, why don't you go ahead? You have a question. Just identify who you are for the record and for everyone to know. You're on here. There you go.
My name is Wes Olds. I work. Hold on a second. We're trying to fix the. If you mute your side. Oh, you're muted? Sorry about that. All right, how about now? Is there still an echo?
We can hear you.
All right, great. I just have a couple clarifying questions. First of all, is the intent for this to include all payments to providers or only payments to providers that are affiliated, the payments that are affiliated with the members that are eligible to show up in VCures?
I will bring that question back to OnPoint, and actually I'll involve
on my laptop. Oh boy. Greg, can you come back in the room? I have audio.
Lindsay, we're here. So this is Kay Davis from OnPoint.
Okay.
Hi.
Hi.
And I have Katie McGraves Lloyd and Emma Scott here.
Great.
So we're here.
Oh, well, then
to
I'll just
answer
let you
questions.
answer.
Yeah.
Great.
Sure.
I think he's still trying to get audio. So,
Okay.
but we may also, before you answer, Kate, I think we may also want to just clarify with legal, who I think is on the call. What I was leaning towards is that we it can only be for the members. It can only be the payments for the members who are submitted to VCures. That's like my gut thinking about the law, but I'm not a lawyer. So I'm going to be quiet now.
Yeah, Lindsay,
Okay,
I don't know. Oh, go ahead.
Use my computer. I'm going to use Greg's computer, so I'm going to talk through Greg's screen. Makes sense. All right. Can you still hear me? Oh, maybe I need to put up Greg's hand if.
Yeah, we can hear you.
Okay. All right. And now I can hear you. So sorry about that.
That's okay. There is a little bit of feedback, but it's okay.
So I only heard part of your answer. So if you wouldn't mind repeating what you said while we were having technical issues over here.
Yeah, so your question about would the payments collected, the non-claims payments collected be for all payments that have gone to providers from Blue Cross, or only for the members who are in the APCD? And being neither On Point nor a lawyer, I chimed in to add that I think it can only be for the members who are in the APCD, but I'm going to let On Point speak, and then if Julia would like to speak as well, to add.
Yes, yeah, we're in agreement. It's for members in the APCD. I actually thought, Wes, that you were asking a different question, and I might have misheard. I thought you were asking if payments were just reflected for non-claims or also fee for service. Was that your question or not your question?
No, that wasn't my question. My question was about whether payments to providers for example, let's say provider A, we give them $100 a month in capitation, but only $50 of that capitation is specifically for VCures members. Would we report 50 or 100? Does that make more
my
sense?
understanding is, yes, it does. My understanding is 50.
Okay. Could we just somewhere in the official manual make that clear that that's the data that's going to be asked for?
Mhm.
Okay. Yeah, I think that's an easy change. Thank you for bringing that up. It's a really good catch.
My second, again, this is more of a language question. On the general file specifics tab, specifically the capitation file specs, the required frequency says annually, but there's language in there about monthly data. And that just confused me a little.
Yeah, do you mean the third bullet?
The second bullet and the third bullet.
Yeah, I think we can modify that. So originally the intent was to capture it at a monthly level, but we decided to change it to annually. So yeah, we can adjust that.
Okay, that was it. I just wanted some language clarifications. Thank you.
Yeah, sure.
Thank you.
Great. Thanks for those questions. Those are timely. Any questions from the council? Josiah?
Yeah, part of this is being new here and not working in this space all the time. Can you talk me through what the state, like what the benefit to the care board and the state is from collecting the annual, the pharmacy and the capitation data elements?
Yeah, so is it okay to talk about it like report specific? I just have
Like an
my
example?
Yeah, like
A
my
report we do?
analyst hat on.
Yeah.
So broad strokes, this will improve what we're able to report on. To get granular for a moment, we have a report right now called Patient Migration, and it's about how patients, where they go for care, a little bit of like the drivers, like diagnosis codes and such associated with it, and to an extent, expenditures associated with that care. We have always wanted to add pharmacy to that report. At one point we did, until we learned how inaccurate the pharmacy cost piece was, because we have no visibility currently at the care board, or actually maybe in any state administrative database, into pharmacy rebates from commercial or Medicare. So we really don't understand what it actually costs the healthcare system for people to obtain their drugs. And I'm using the term cost and healthcare system a little fast and loose, but just all we're able to look at right now in the APCD in terms of pharmacy spend is what was paid for at the time of the retail transaction, which is really different from has like pharmacy rebates sort of that happens after the fact. So understanding pharmacy rebates would allow us to speak accurately to what system-wide pharmacy costs are. In terms of annual payments or capitation payments from Medicaid, for example, one of the most common misconceptions about the APCD, we say we have 100% of the Medicare population in costs, we have 100% of Medicaid, Medicare, Medicaid, and then we have 60%-ish of commercial. We actually have 100% of the Medicaid beneficiaries. We only capture about 50% of Medicaid spend. If you compare what's in the all payer claims database to the CMS 64, there is about a 50% expenditure gap, because many of the services that Medicaid pays for are just not captured in the current database or with that current infrastructure, the claims, infrastructure of how these data are organized. So we're hoping with the non-claims payment file, one of the things that may come out of this is that we're able to capture more with some granularity of like the true Medicaid spend. That would enhance all of our reports actually. So yeah, I hope that's like.
Yeah, that does help. So that will leave us, so we'll have 6 categories of kind of, I'll call them finance, like they're money streams. It looks like, are there others that are beyond that are not included yet that maybe we'll consider for a 5.2 or a 6.1 or something?
Yeah, I'll let OnPoint speak to that. I think that there were more file types in the CDL, but OnPoint, maybe you want to take that one.
I understood the question. Sorry, could you repeat that or reframe?
Yeah. So there's 6 categories here: the medical claims, pharmacy, dental, the annual payments, the pharmacy rebates, the capitation.
Yes.
Those are all ways that money moves around within the system, so we can have visibility into that. Are there other categories, other buckets of money that we'd want to look at including in a 5.2 or a 6.1 of this spec?
Not from the APCD Council in terms of like a uniform template for collecting the information. It's an interesting question. So yeah, I think that it's to sort of like take a broader answer. There are dollars that flow through the healthcare system that we will never have visibility to. Like I'm thinking about pharmacy payments, right? Like payments between like wholesalers. We won't ever be able to see that, but for the data that we're able to reasonably collect from submitters and define, I think this is a good universe of file types.
Okay, thank you.
Is it fair to say that there's also a bunch of care that happens that isn't, measurable or not easily measurable in dollars because it's free care, and so you've got medical activity or whatever kind of activity you want to call it, and so that's another bucket that's not necessarily dollars.
Yeah, it's a good point. And just building off that, you think like behavioral healthcare, someone might be having like telehealth psychotherapy, but the provider is not in their insurance network, so they're paying out of pocket for that. that's care that we don't see in BCARES, but yeah, definitely.
Here you go. Yep.
Okay, any other questions from the council? So we did notice a vote on this. I know there are a couple of changes, or
Yeah,
no, you want to wait?
Yeah, that was our mistake. We had,
Okay.
this kicks off the public comment
Perfect.
period, the 30-day public comment period.
Okay. Oh, right. I remember this now.
Yeah,
Sorry.
yeah. So we're kicking off the 30-day public comment period where we'd love to hear from all of you, all of our stakeholders. And then at that point, the next Data Governance Council meeting that would come after that would be the August 5th meeting. And so potentially we could vote at that meeting, but also there may be enough feedback that it warrants further discussion and consideration. So I don't want to say for sure that that's when the vote would be, but yeah.
So the next steps are we have an open public comment period starting today for 30 days. Have this posted on our Data Governance. Yeah, it's already up there. And is it under the board public comments too? We should put it under that too. Our public comment section.
Oh, yeah.
We should put it under that too.
Yep.
So we'll do that. And then we'll look for comments and feedback from stakeholders and anyone else. Go ahead, Lowry.
Thanks. So just to be clear, these new files are purely summary. So you're not going to capture the detail of what actually occurred for care, like all the claims data, right?
Yeah, correct. Yeah. Go ahead, On Point, sorry.
Yeah, so the annual payments file, you're right, it's an annual summary. We do have some granularity like by billing provider and contract in terms of summarization. I just jumped in because the capitation is like the monthly capitation amount at the member level, even though we're collecting on an annual basis. So we do have capitation at sort of like member time period. And then pharmacy rebates obviously is a summary by year.
And sorry, I'm also not too up on this world of the financial side. Do these dollars reflect some activity that is in the claims data and the pharmacy data? So it's like supplementing just the dollar amounts that for the activity that are in the claims?
So like yes and no. So if we think about the pharmacy rebates file, there'll be, just imagine like $2 columns for a specific drug and time period. And so one of them is like the amount paid, like the amount the insurer paid, and that would be reflected in the claims. The other one is the rebate, and that's what we don't have in the APCD, and that's really the value of collecting that. So that doesn't already exist. So one is new and one is exists in another format.
So that's on the pharmacy side. What about on the medical claims?
Yeah, so in the annual payments file for medical claims, we have fee for service totals. There is a category that's fee for service, and that will be reflected, in medical claims on the APCD. So that's kind of a nice little validation, but there is new information in the non-claim spending. And so we're capturing spending for non-claims by particular categories. So for example, like total cost of care shared savings programs versus capitation versus population health management payments, et cetera.
Great, thanks very much.
Any other comments from the council? And we can open it up to the public too, if there are any other public comments from stakeholders or questions? Great. All right. So look for those that posted on our website. And if you have any questions, reach out to Ravi and we can make sure look at information they need. Okay. So the last item on the agenda is, well, the nearly last item.
Yeah.
Is now we're going to get into a little more detail on S126. I kind of jumped the gun there, but Lindsay is going to review that. And I think it's really the start of the conversation.
Yeah.
Just to tee it up. Go ahead.
Yeah, so S126, as Susan said earlier, it did pass through, do we say pass through committee? Is that the right way to say it?
It passed
through-
the full legislature.
It passed the full legislature, thank you, and it's now with the governor, and so S126, I think I had it pulled up here
Yeah,
before,
if you
but now
haven't, I
I'm
can pull it up too. Lindsay's having her computer
Now I'm
running out of
struggling to
too.
find it. Hold on. I opened it, I had it ready, and then I lost it. I just wanted to pull up the full language. We don't
Yeah.
have to read it all, especially with where we are with time right now, but I just wanted to share out that it has passed, and section 10 specifically speaks to here it is. Here we go. The integration of healthcare data and reports, related reports, it's like colon and reports. And so it is instructing the Agency of Human Services to collaborate with the HIE Steering Committee in the development of the Unified Health Data Space. And the goals of that are to improve patient provider access to relevant information, increase efficiencies, and decrease administrative burden on providers, ultimately reducing healthcare system costs. I think it's extremely relevant to what we're doing with the APCD because this has it instructs the agency to work with the HIE Steering Committee, and it gives the HIE Steering Committee the oversight of privacy and security requirements, the decision of whether to integrate clinical and claims data, and if the HIE Steering Committee decides to do that in like describing all of that and making all those decisions. It also assigns I think it still assigns a report to AHS. I might be wrong about that.
It
Maybe.
changed at the very end.
Oh, it did?
But I'm
Okay.
not sure if it ended up in there or not. Will is here, he would know.
Oh.
No, is Will still here?
May not be.
Okay. There he is.
Oh, does it still assign a report on this to AHS or the HIE Steering Committee?
Yes, it assigns a report that's due on January 15th, I believe, of 2026, and then an annual report moving forward in every January after that.
Yeah. Okay. Yeah. So this is something that we've had our eye on this whole time. We've been working with AHS we've been working in collaboration with AHS on the Unified Health Data Space. What I want to say, like the development of this idea and like what is everything that would need to kind of fall into place. And so this legislation is really timely. And I would say I'm excited. I'm excited about it. I think it's great that it's in the healthcare reform bill, that the language, made it in there. So yeah, we just wanted to bring it to your attention, let you all know that it is on our radar. We are already actively working on it, and we're going to continue to work.
And it will come back to this group. I mean, that's the other thing too. Thank you, Lindsay. That was a really good summary. And thank you, Will. We have our own data linkage process.
Mm-hmm.
And so we'll continue to work with you all. And then the other thing that's related to this is that as part of S126 as well, the Green Mountain Care Board has an official representative on the HIE, the Health Information Exchange Steering Committee. Whereas before we were I don't know what our role, I don't know what the exact title was, but we attended those meetings, but we were not a voting member. And so now we will be a voting member. So that also ties into this work and our input on that. So I just wanted to announce that as well. And then maybe it's pylon, but just might be interesting to the group. We also, the board requested, it was not in this bill, it was in S63, that the board did not have oversight of the vital budget anymore. We asked that come off of our plate. That was, and for folks, I'm looking at people on the call who may remember this. Now I'm just dating myself because the reason the board had that oversight duty was because at one point there were only 3 days cash on hand at Vital. It was a real problem. They have moved into a very different space. They're doing really well, and all of their contracts are overseen by AHS. So the legislature agreed with us, and we do not have that duty. And then that HIE, with the HIE report, we do not vote on that either. That was the other change.
Yep.
The strategic plan. Thank you. So just there was a lot that happened in this legislative session. We'll bring other things up at our next meeting if as they are relevant. We'll all be working very hard to implement them, including this really I think good space moving forward for section 10 of 126. Any questions, or do you want to say anything else?
I just wanted to say that was all I had.
Okay, great. Yeah, it really was good work with, as I said, the healthcare advocate, AHS, and GMCB coming together to work with the legislature on this. And thank you, Lindsay and Will. And I don't see Eric here today, but Eric, is he here? Eric, I don't know, from the HCA. What's Eric's last name? Schulteis, thank you. Drawing blank. Great. Okay, so I'll just open it up to public comment in general or any sharing. Yeah, that's great. Oh, there you are, Eric.
Oh, hi, Eric. Oh, and your hand is up.
So I just want to add a little more color, and in classic fashion, I'll probably be a little more blunt than I should be.
Great.
I think this walks an interesting line between the kind of tech utopians that data solves everything and the folks who think all data analysis should be like this profound fear of the digital panopticon, right? Like it kind of allows, sorry for the Foucault reference. I think it allows AHS to continue with its
My computer's gonna die.
kind of proving up the use cases with the Medicaid data, and allows the continued kind of optimistic but skeptical idea of integration of clinical and claims data that I think the steering committee expressed last year with S10, that it requires a majority vote of this steering committee, which is the first time that the steering committee has an absolute say on things. In the past, it was primarily advisory or kind of dependent on, will, honestly. So I think, a lot of people have something to be, can be happy with this outcome. I think, hopefully this puts to bed for at least for a while, this the ingestion of VCures debacle, which seems to have plagued us in recent years. And I think more importantly, what I considered a victory either way, whether, this last minute language came to be in conference committee, was like, I think it kind of was emblematic of a working relationship with the board and AHS and HCA, and I think at various points along the process required a fair amount of trust and forthrightness between the parties that I think we have not always had, quite frankly, between the various actors. And, you know, I think that in and of itself is a good outcome that benefits everyone.
Thanks, Eric.
Thank you, Eric.
Okay. Any other public comments? Okay. I was trying to find the next meeting. Is it in August, Ravi?
Yeah, August 5th.
Okay, great. August 5th. It should be on your calendars already. So we look forward to seeing you then. I should ask, is there any new business to come before the board? Okay, then do we have a motion to adjourn?
So moved.
Right. And I'll second that. All those in favor, say aye. Aye.
Aye.
Aye.
Thank you all. Great meeting. Thank you. Take care.
Thanks.